I know we are moving towards the third speaker. I'll take little more time to introduce the third speaker. But I want to tell you, okay, what happens. We have seen that we have to control our blood pressure. We are controlling our blood pressure. So we are healthy from within. We want to look beautiful from outside. So we had a cosmetologist who actually told us how our skin can glow. We can remain what we are. It will just enhance our beauty. Then comes to the resolution of the 31st. Whenever there is 31st of the year end, what is the resolution you most of the people take? Anybody? Weight reduction or? हाँ, तो सबका resolution एक ही होता है. 31st आया नहीं, and we have to start with what? This time I'm really going to lose weight. So by the time again the 31st comes, we don't lose any weight. We are where we were the last year also. We take the help of the diet plans. We spend on the diets, we spend on the yogas, we spend on the prescriptions as well. But then the real hero comes in. So can anybody tell me who is the real hero when the diet fails, when the drugs fail? Who's the real hero to make you lose weight? सर को चॉकलेट जाना चाहिए ना, जेसिल, पूर्वी, बहुत सारा आंसर दिया उन्होंने. So you are right. We all know when the diet fails, when the prescription fails, we take drugs for years together, but nothing helps. So then I feel, for me, who's the hero? Hero is the bariatric surgeon. Yeah. So I think we are ready with the hero who's definitely going to guarantee us for the weight loss when all our diet plans fail, when all the prescription drugs fail. Then we have the hero who comes in to combat with the weight loss. And then we have Dr. Manoj Jain, who's
Hi.
going to help people
I'm
who
audible?
are not able to lose weight.
I'm audible?
Yes, sir.
Yeah. Okay. So I would like to thank all the organizing person of KMACON and also thank Nanavati Max Hospital for giving me the opportunity to talk on my favorite subject, that is bariatric surgery, and on top of it, robotics. So I will be talking about robotic and bariatric both. So just Dr. Aarti has already given my introduction. So I passed out from KM Hospital in 2002, so 23 years into practice, now 24 years into practice. So I have joined Nanavati Max Hospital as a director in gastrointestinal, laparoscopic, bariatric and robotic surgery. Previously I was in Kokilaben Hospital. I worked there for 6 years and now I shifted as a director here. So I have done fellowship in different parts of the world. So I have done my fellowship in colorectal surgery from South Korea, fellowship in bariatric surgery from Taiwan. Then I did fellowship in HPB surgery from Germany, and lately I've done fellowship in robotic surgery from Cleveland, USA. Before giving talk, I always thank my mentor, Dr. Abhay Dalvi from KEM, Dr. CK Wang from Taiwan, and Dr. Mufazzal Lakadwala, you must be knowing, who has taught me basic laparoscopic surgery and bariatric surgery. So apart from bariatric surgery, I do all general GI surgery, which include basic laparoscopic and laparoscopic gallbladder surgery, appendix surgery. Then I do all complex hernia surgery, which are more than 10 centimeter defect, incision hernia, redo hernia surgery. So I do all different type of complex hernia surgery which are possible to do. Then I do foregut surgery, hindgut surgery, then solid organ surgery, and bariatric and metabolic surgery. So it is not just that I am doing only bariatric surgery. So I am doing from piles, say bariatric, सब कुछ करता हूँ मैं. Okay. So now from this audience, everybody has seen the era of open surgery. Okay, you have seen the era of open surgery where everything was big. The scar was big, the pain was big, the recovery was big. Okay, and then we shifted. So when I joined in 1999 KM, okay, we just shifted from open surgery to laparoscopic surgery, and I was one of the first to do lot of first surgery by Dr. Abhay Dalvi, that is left nephrectomy, left adrenectomy. So I was witness to that. So we, from last 30 years, we are doing laparoscopic surgery. Then from 2000 onward, the world has changed to robotic surgery, but in India it took about 10 years. So from 2010, robotic surgery has come to different specialty in India also. And lately, since 1 year, we are into telesurgery. You must be reading newspaper where you have seen telesurgeries, like people operating from Hyderabad to Mumbai, or from Mumbai to Jaipur. And recently, we have a live surgery from what you call Shanghai to KDH by Dr. Yuvraja. So world is changing from open to laparoscopy to robotic and now the telemedicine. So what is the need of doing robotic surgery? Like I'm doing laparoscopic surgery since last 25 years. So what is the need to change? So in laparoscopic surgery, even after having experience of 20, 25 years, there is still difficulty to perform difficult surgery because laparoscopy is a 2D image, okay? And it is a rigid instrument. So the instrument doesn't move or articulate, and the instrument are controlled at a distance. So there is a lot of fulcrum effect, and because of all this, the precision, the dexterity is hampered. So you cannot do a difficult surgery like surgery in the thorax or surgery in the pelvis. It becomes little difficult for the instrument to reach there. So that's why laparoscopy becomes little difficult. And you see here, it is a higher surgeon. So if you do laparoscopic surgery for more than 2 to 3 hours, your body will start paining, okay? So long surgery like complex hernia surgery or colorectal surgery where the surgical time is high, laparoscopy become little difficult because, and suturing also become difficult on the roof or in the pelvis, the laparoscopic suturing become little difficult. And you have to depend on the camera person. हमेशा बोलना पड़ता है इधर दिखाओ उधर दिखाओ कैमरा इधर बराबर नहीं दिखा रहा है. So you have to be dependent on the camera person. So there is a lot of assistance required in laparoscopic surgery. And so if you see and if you compare robotic and laparoscopy, you can see the robotic surgery is a 10x magnification. Like you have 2 megapixel camera and a 10 megapixel camera. So it is a 10 times more magnified. It has a 3D image. So because of the magnification and 3D image, okay, the clarity is very good. And also the instruments are endo-wrist movement. So they move only at the tip. So they can move like your hand. So there is a 7 degree of freedom, 360 degree of rotation, and 540 degree of rotation like our hand. So the laparoscopic instrument just move up and down or sideways. It cannot rotate. So in this, the endo-wrist instrument can rotate 540 degree. So these give like how we are operating by hand. Okay, so because of the 3D image, because of the 10x magnification and endo-wrist movement, the precision, the control, and the dexterity is very good. Also, the surgeon is sitting and operating. So the ergonomically it is very good. There is no tremors. So as the age advances, like I am 50 plus, so as the age advances, you have little tremors. But because of the robot, the tremors and is gone. And ergonomically it is very better. Suturing is very good because of the endo-wrist movement, the suturing on the floor or the suturing on the pelvis, it becomes very easy. And it has a shorter learning curve. My third year student can also perform a robotic collie. I performed robotic collie after 4 to 5 years of my training. But robotic surgery, even if you do 20 cases, okay, then you can master the robotic surgery. And it requires less assistance. So the camera, everything is in your hand, okay? You don't have to depend upon the assistant. You can shout only on yourself. You cannot shout on the assistant. So most of you must be knowing the Da Vinci robot. So Da Vinci robots is one of the robots. There are many robots. Now we have Indian-made robots. So there are 2 Indian-made robots like SSS Mantra and we have Mizo by Merrill. So we have now Indian-made robot also. But Da Vinci is one of the best because it's a 6th generation robot. So we have 3 in robot in this. So one is a patient cart, then surgeon control and vision cart. So in patient control robotic cart, there are 4 arms, okay, which are docked into the patient body, okay, through the trocars. Then this patient cart is controlled by the surgeon console. So we have a view monitor there, then we have hand joysticks, and then we have all the cauteries and the camera in a pedal. So it's like driving a car. So everything works. Your mind works, your hand works, and your foot works. So everything works in robot. It is not that robot is working. We are also working behind that. And we have a vision card which has a 3D image, CO2 insufflator, and light source. This is a small video. Can you run the video? Click. So these are small video of docking. Previously, people were saying that docking will take long time, but here the docking just take one minute. Just click it. म्यूट कर लेना, आवाज म्यूट कर लेना. Okay, so now this are the sterile drapes. Okay, if you see this, these are all sterile drapes. So before the sister, when the patient is getting intubated and ready, the sister will drape all the four arms. Okay, and these arms has a sensor. So the company will know whether how many arms you have used, and these are all recorded on your app also. So we will know which surgery has taken how much time. Then, so once all the four arms are draped, okay, and then the patient card is brought towards the patient, and these are special trocars. So these arms are clutched to the trocars, and then we put the instruments. So each instrument is sensor. You can use only 20 times. So each instrument cost is around 2 lakhs. So around one instrument is 20,000. So after docking, we put the camera, and then we put all the different instrument under vision. So hardly it takes 1 minute to dock the robot. So different surgery, we have to place the robot in different areas. And now you can see with the hand movement, just the wrist movement, we are able to perform the surgery. So this is my data. You can see the advantage of robot. Okay. So there is a length of stay is decreased. Then the operating time is also same. Initially the operating time may be little more, but as you cross 50 surgery, the operating time become less. Estimated blood loss is hardly we use any hospice for the routine surgeries. Okay, even in bariatric surgery, I don't use any hospice. And the surgical site infection is also less, complication rate is also less, and the most important is pain score. Second day morning, that is next day morning, the patient is smiling. If I operate a lap chole or lap hernia and a robotic chole and a robotic hernia, the smile on the face next day is give you the thing that robot is for the patient and it's not for the surgeon. Lot of colleagues and lot of people are saying that robot is just a gimmick and it is only for the surgeon benefit. No, it is definitely the pain score is less. And so once I did about 20-30 cases, I felt that it is the patient is, and we get a patient which are little VIP in tertiary center. So the pain score is the most important part in robotic surgery. Now I will talk about obesity, and then I will go into a last section that is a video. So obesity is nothing but accumulation of fat in relation to lean body mass, and it is calculated by BMI. So the slide Dr. Aarti has shown, the most important clinical, this is a BMI chart, which is a nothing but a ratio of weight and height in kg, weight in kg and height in meter square. So as a physician, everybody should know what is the grade of obesity. In the OPD, we take height, check the BP, sugar. I think as a consultant, as a physician, every patient who comes to your OPD should, in their indoor paper or case history, you should mention the BMI. You should tell your compounder or whoever is outside to measure the height and weight, because this is the most important marker for all the chronic diseases which we have. So the grade of obesity, you can see the normal weight is 18 to 22.5. Then we have overweight, mild obesity, moderate obesity, severe obesity, super obesity, and super obesity. Because depending upon the grade of obesity, we determine which type of surgery or which type of management or which type of treatment to be given to the patient. So before going into the type of surgery, okay, I will just give a 5 case thing that we don't just operate for weight and looking good. We operate for comorbidity also. So this is one of the first patient which had all comorbidities, whatever you name, diabetes, blood pressure, pulmonary hypertension. She was on CPAP machine when she came to my OPD. Okay, and she came for just gallbladder surgery. So I told the patient and the relative that if you do a gallbladder surgery, the risk is same. And if you do both the surgery together, the risk will be the same. So after 2 months of counseling, she was ready to get operated by me. She was 133 kg with a BMI of 54. So after around 10 months, she came down to 90 kg. And all her comorbidity, that is diabetes, pulmonary hypertension, varicose vein, everything came down. And at the end of 18 months, she was just 18 kg and she went to Kashmir and Leh Ladakh without any oxygen. So it is not just weight loss, it is resolution of all comorbidity, and she is now able to play with her grandsons. Sorry. Slide. Next slide is not changing. Slide change. This is a second patient. He had obesity with severe OSA. He had because of the sleep apnea, he was not getting proper sleep in the night, and in the daytime in the office he was drowsing. Okay, he was very drowsy, and because of that he was removed from his job. And then one of the family physicians referred this to me, and we did a simple sleeve surgery. He was 135 kg, and now after the surgery, simple sleeve surgery, he is 85 kg, and he has now got a good executive job. So this was second indication. Then this is a common scenario in a clinic, a patient coming with the parents, कि इसकी शादी नहीं हो रही है because she is overweight. So she was 140 kg, and in 6 months she has come down to 100 kg, and now she is 80 kg, 80 or 78 kg, and she is already got engaged. This is a 3 years old patient. This is a patient who had infertility because of obesity. Again, this is a common scenario, and she was 120 kg, and she is now at the end of 18 months, she was 67 kg with a BMI of 29, and there was complete remission of diabetes. Okay, so with bariatric surgery, you get near complete remission. In around 80% of the patient, you will get complete or near total remission of diabetes. So last patient, this patient was brought by his husband. Okay, and she was 45-year-old with 110 kg and about to get divorced because of the weight. Okay. And she was depressed because of that, and she was on 3 antidepressive drugs. And at the end of around 18 months to 2 years, she was 70 kg, and now she is thinking to give divorce to the husband. Okay. Okay. So what are the treatment options? So as I told you, treatment depend upon the BMI. Okay. So in patients who are overweight, between 22 to 27.5 BMI, we just give diet. Patients who are in grade 1 obesity, we give diet and exercise. Patients who are in grade 2 obesity, okay, we give, that is between 32.5 to 37.5, we give diet, exercise and drug. Everybody knows what are the drug available. Okay, we have a lot of injectables and tablet, oral form, Manjaro, Ozempic, Wegovy, Urpic, all this. Okay, so we manage with diet, exercise and injection. But once the patient crosses 37.5 BMI, or 32.5 BMI with comorbidity, then our role comes, okay, and then we suggest surgery. But if you see, behavior and modification is very important, and diet and exercise is very important whether you take injection or whether you do surgery. So diet and exercise is an integral part of any obesity management. So you have to tell the patient, this is not a shortcut, injection is not a shortcut, bariatric surgery is not a shortcut. You have to do diet and exercise. Because a lot of patients comes to me with a weight of 80 kg or 90 kg and they want surgery. So I told no, surgery is not indicated in you. You have to do diet and exercise. You have to struggle and you have to maintain with diet and exercise. So according to the, as I told you, the indication, any patient who are about 37.5 or patient who are about 32.5 with comorbidity, it is the indication of surgery. Now surgical procedure, there are 3 main common type of surgery. Okay, the pointer is moving. Okay.
So we just have 2 minutes
Yeah,
more.
so okay, so I will just, so these are 3 basic surgeries. Then we have a neo-metabolic surgery only for diabetic patients. Then these are surgery for revision bariatric surgery. So there are 9 different type of surgery. Okay. So depending upon the type of this patient, we decide which surgery to be done out of these 9. So age, BMI, comorbidity, C-peptide. The higher the comorbidity, we go for bypass surgery. So patient asked me, कि मैं बाहर निकलूँगा तो कैसा दिखूँगा? Okay, so I told नहीं, you will be same. Only after few months, you will gradual weight is there. So this is a gradual weight loss. So you lose 30% in 3 months, 50% in 6 months, 65% of the excess weight in 12 months, and 70% in at the end of 1.5 year. So why robotic? Again, I told you there are patient advantage and surgeon advantage. The main advantage is the leak. Because of the robotic stapler are AI built stapler. So there is a 0.1% leak rate and very 0.001% of bleeding. So these are 2 main important point of robotic bariatric surgery, that the leak and the bleeding is very less. And then there are surgeon advantage also. So we will directly proceed to the case. The small video of 2 minutes, as RTS told, just 2 minutes. So I will play the video and then we'll take a last slide conclusion.
Video, circle.
So you can see this. This is a sleeve gastrectomy, a 24-year-old only. Okay, and in one hand I have a vessel sealer, and other hand I have a grasper, and the 4th arm, which is in the side, I can manage the 4th arm also. Okay, and this vessel sealer has an angulation, so I can work on the angle of his. So it work as a dissector also, and it can take up to 1 centimeter of vessel. you can see how I am able to dissect with the vessel sealer and the angulation. This angulation is not possible in laparoscopy. So in morbid obese patients who are super 180 kg, 200 kg, robotic is a boon. So after doing the complete adhesive lysis, then we'll fire the stapler. Just 2 minutes I will take, not more than that. Yeah. So these are the staplers. These are the AI built stapler. So it will tell what is the thickness of the stomach, and then here in the down it will say whether it is clamping or not. You can see the yellow thing. Okay. Then it will pause for some time. Okay. And then it will fire, or it will tell that you have to change the stapler. So these are all AI built stapler. So people are afraid of bariatric surgery because of leak and bleeding. Okay. Patient can die. They think, but this stapler, there hardly any leak rate, because you can see hardly any blood along this. So around 5 to 6 stapler we fire, and it should be a J pouch. Okay. So here the camera is in my hand. You can see the articulation of the instruments. Okay. And I can rotate this what you call stapler with my own. I don't require any assistant to rotate. In laparoscopy, I have to tell the assistant to rotate my stapler. But here I can rotate on my thing. So last take home message. So why I kept this picture? Any idea? No. Okay. So this is, she was 96 kg and now she is 52 kg, and she has not told her husband also, and came to me, got admitted on Saturday morning and discharged on Sunday. Okay. And she has not told her husband. Husband came to know after 6 months. Okay. Because she was doing regular diet and exercise. The husband thought that wo diet or exercise se kam hui hai. So I wanted to tell it, bariatric surgery is safe, effective and feasible. Robotic surgery is not a future but a present. Robot does not replace human, but it enhances the skill, and equivalent outcome are there as compared to open and lap. Okay. And last take home message, thank you everybody. Thank you Kandivali Medical Association and Nanavati for giving me the opportunity to talk.
Thank you so much, Dr. Manoj Jain, sir. Now I request my team to please guide sir towards the KMA's Wall of Fame. And I also request the team to felicitate our sponsors, Nanavati Max. So the winner for the last quiz is Dr. Jainam Shah. Is he here? We request the team to please connect with Dr. Jainam. Okay, so now before we move on for the very important ceremony, we'll have one more quiz right now. So everybody has the number. Please look at the quiz over here, which will be displayed, and feed your answers. We have 1 minute for that. Okay, so we play the quiz after the inaugural ceremony. So now we move on to the very important part of the conference, that is the inauguration and Dr. C.K. Roy Gaga oration. And for this, I would like to invite the President of the Kandivali Medical Association, Dr. Utpal Seth, to please be on the dais. Now may I request the General Secretary, Dr. Saurabh Dani, to please take your place on the dais. I now request my scientific team, Dr. Bela, Dr. Parul Panchal, to please guide our Managing Trustee, Dr. P.D. Shah sir, on the dais. I request Dr. Monica, Dr. Madhvi, to please guide today's chief guest and the distinguished speaker, Dr. Alok Modi sir, on the dais. Sir, please, Dr. Monica, Dr. Madhvi, please assist sir to be here on the dais. I request the AV team to please ready with the Saraswati Vandana when we do the lamp lightning. So I request the President, Secretary, Managing Trustee and our guest for the day, Dr. Alok, to please come ahead for the lamp lightning. Can we please play? Saraswati Vandana. Thank you, everybody. This was very enlightening for the entire atmosphere of the hall A and B. I see the president and the secretary of Borivali Medical Association. I request Dr. Saurabh to please felicitate them. Dr. Paresh and Dr. Jeenil, please. Meenal, sorry. So as I said, talia bajti rehni chahiye. It helps to improve the blood circulation. It helps to move the energy in the hall. Yeah. And I do see the president and the secretary of the Malad Medical Association, Dr. Dandekar and Dr. Preeti Mehta. I request them to please come here. Thank you. So now, the time. The president of Kandivali Medical Association, Dr. Utpal Seth. We all know he's an orthopedic surgeon practicing at Kandivali West. He takes care of the pains which are acute as well as chronic in nature. He also gives a holistic approach whenever it comes to treating the patient and healing them as well. So when I look at my president, Dr. Utpal Seth, he defines the qualities of the president of the KMA as well. Because as an orthopedic, he does not only restore the mobility, confidence, and hope in the patient, but when it comes to the team of the KMA, he equally restores the mobility, the confidence, and the hope of the entire KMA committee. So when I think about him, I think he's a clinician by the skill, he's a leader by his action, and he's a mentor by nature. With his journey beautifully bridges the science of healing with the art of leadership. So with this, I would like to invite the president for his address for the delegates, Dr. Utpal Seth. So friends, big round of applause for the president. Sir, over to you.
Thank you, Arti, for those kind words. Okay. So I'll try to be brief. Prachi. Yeah, when I tell you, I'll let you know. Okay. So, good morning, seniors, colleagues, and friends. Standing here today as president of KMA, I feel a deep sense of gratitude to everyone who has contributed to my journey and to my family. KMA has given us friends for life, irrespective of age, with a bonding of love and respect. I also harbor excitement from the appreciation that follows living this role over the last 6 months and for the remaining part of my tenure. As we begin a new calendar year, I would like to wish each one of you and your families a very happy, healthy, and fulfilling 2026. When I joined this organization 2 decades ago, I wanted to contribute. I started working with those who are trustees today, belong to the advisory board, or have retired from active KMA roles, or left for heavenly abode. They taught and trained me, and I learned by observing their calmness, dignity, and discipline. But what shaped me most were the people who trusted me, guided me, corrected me, and allowed me the freedom to grow, and slowly, role by role, I grew. There is a long list of those who have influenced and shaped this journey, and as Belubi sir always says, KMA is a personality development organization, and I am a living testament to that. To all the seniors from those early days, and to our trustees, advisory board members who gave me that freedom, thank you very much. Your openness, encouragement, and your trust have meant a great deal to me. To my friends, Rohit, Shilpa, Amola, Tushar, and many more, thank you for walking beside me. Thank you to the young brigade of the current managing committee. Your energy inspires me every day. And thanks to members of KMA at large for the trust and respect bestowed on me for all these years. I stand here today only because all of you stood with me. The respect I received from all of you makes me more responsible, accountable, and committed to doing what is right for this association. Your trust doesn't make me comfortable, it makes me careful. On a personal note, I would like to thank Kirpa, my wife, for her unwavering support throughout the demanding years of my journey with this association. Through KMA, she too has made friends for life. As you have already seen, this KMACON marks a significant milestone, our first ever two-hall conference. The other day, Atul sir told me that this is the first time in suburbs something like this is being attempted. So you have already experienced the first session, and I am sure many of you were both excited and little skeptical about how this would unfold as we have been during this journey. We wanted to provide a new experience for our delegates, and for us, it also symbolizes growth, maturity, and confidence. It reflects countless hours of sincere, unseen effort from individuals who worked with dedication to make today possible. The scientific foundation of this conference rests upon the remarkable all-women scientific team, Dr. Aarti, Dr. Bela, Dr. Madhvi, Dr. Parul, Dr. Monica. Your hard work, sincerity, and intellectual commitment form the academic core. Our organizational strength has been supported by Dr. Anurag Agarwal, our treasurer, Dr. Vinod Birajda, Dr. Vipul Vakil, Dr. Jaisal Sanghvi, Dr. Deepak Rasal, and Dr. Bhushan Keskar, each bringing method, clarity, and dedication to every task entrusted to them. I truly wish I had the time to acknowledge each contributor individually, because every person has played a meaningful role in today's events and will play till the end of the show to make it successful and memorable for all of you. But the interest of time, allow me to express my heartfelt gratitude collectively. I acknowledge the contribution to the smooth functioning of today, right from reception, registration, food and hall arrangements, stage and AV management, coordinating with sponsors, ensuring both halls are running seamlessly, management of the distribution of lucky draw prizes and delegate gifts at the end of conference. Their quiet efficiency is what makes an event of this scale look effortless. Which brings me to the captain of the ship, Dr. Saurabh Dani. Saurabh is the man who kept the conference organization running with precision, calmness, and remarkable consistency. His "mane kahin farak nathi padto" mindset is exactly what keeps us steady. Saurabh, thank you for your partnership and for your patience with an active president. This conference is also enriched by a very special academic moment. We are honored to have the late Dr. C.K. Roy Gaga oration, which will be delivered by Dr. Alok Modi. He will be speaking on a topic that is extremely relevant to all of us: use and misuse of artificial intelligence in clinical practice. I am certain this oration will provoke thought and meaningful discussion, and I look forward to it, as I am sure all of you do. Before I conclude, I want to briefly highlight two important initiatives that reflect the values and direction our association has taken with the support of every member. The first mention is the compression-only life support calls awareness drive undertaken by the Public Awareness Cell, a steady grassroots effort that equips citizens across our suburbs with essential life-saving skills. The second feather of our cap, as Saurabh has already mentioned, I will talk something about that, is the Jai Hind project, our urban forest initiative in Kandivali, Malad West, because it is at the junction of Kandivali and Malad, based on the Milwaukee forest model. I will show in brief the project right from inception to where it stands today. Prachi. So this is the way this is the site area which is in the Goraswadi ground. This was the site survey done before we started. Site leveling. So we have a drip irrigation facility. We have done mulching, we have supported sticks to the plants. This is the layout, and this is what it stands currently today. This visionary project was brought to life through the remarkable efforts of Dr. Dipesh Savla and Dr. Vinod Birajdar, who have assured continuous support in procuring resources to maintain and sustain the project. It is a quite meaningful contribution to the community. As I close, I want to make a sincere appeal to all delegates present today. Our association thrives when its members participate, contribute, and take ownership of its initiatives. Whether through your time, your ideas, or your support in kind, your involvement truly matters. I especially invite each one of you to contribute in whatever way you can to the Jai Hind project, a legacy of green urban transformation that will stand for generations to come. Let us strengthen this association together and let us nurture this forest together. Thank you.
Now I move on to call upon my General Secretary, Dr. Saurabh Dani. We all know he's a great gynecologist attached to Cloud9 Hospital. But what I don't want to forget to mention, he's very, very, very tech savvy. All the digital things you see here, the KMACON goes from being paper to completely paperless. So all the credit over here, along with the team, goes to Dr. Saurabh Dani. A big hand of applause for sir. He's one of the person truly we appreciate for transforming KMA conferences from papers to paperless, replace the lucky draws with the quizzes to seamless QR codes you see at multiple places, whether it's a scientific agenda, whether you want to play the quiz, whether you want to go to stall, everything needs scan, scan, and scan. And over to Dr. Saurabh Dani. We welcome him with a big round of applause.
So thank you, Aarti. So when we talk about the president, he's a very active president. So that reminds me of President Abdul Kalam, who was also a very active president. Typically, KMA has been like a government of India. The Prime Minister does everything, so even the Secretary does everything. And it's absolutely fine for me to do it. But I think, Aarti, I couldn't change you. You are still using a paper. Anyway, it's for next time now. So coming to the very most important part of the inauguration is the Dr. C.K. Raiga oration. And before we introduce the orator, I would like to introduce who is Dr. C.K. Raiga. Video, please. Volume, audio.
Dr. C.K. Roygaga's life was an inspiring life of commitment to medical practice, community service, family life, and personal growth. With 50 years of practice as family physician, he helped a number of people with his knowledge, experience, and empathy. As Vice President of Ashwini Kumar Medical Relief Society and his association with same for long 40 years, as a head of Defeat Tuberculosis Project, which helped over 50,000 TB patients, as founder of One Vihari Parivar for senior citizens, which included counseling and group therapy, as an initiator of Aushadh Ganga Yojana, providing medicines to needy, as a launcher of Anemia Project, and as the president of KMA,